Hi, as you heard, my name is Marta Boffito. I work at Chelsea Westminster Hospital in London, and it is a pleasure to be here. And thank you for the invitation to discuss our experience in running a clinic for people living with HIV who are aging. These are my disclosures. The reason why we are talking about the importance of providing individualized care as much as possible to people living with HIV who are aging is because data in the literature show that people aging with HIV might be more vulnerable to comorbidities. And we're going to look at what these comorbidities may be. Importantly, also, having different health matters will lead to having to take medications to treat such health matters. And people with comorbidities are more likely to be on polypharmacy, be on many medications. And this has been shown for people living with HIV across Europe by a list of different studies listed in this slide that again show that polypharmacy, which means being on 5 or more medications, is prevalent among people aging with HIV. We published a study from the POPI cohort study, which looks at health outcomes in people aging with HIV in the UK and Ireland, showing that people living with HIV are frequently on polypharmacy, especially if they're older than 50 years of age. And therefore, they're more prone to develop drug-drug interactions between antiretrovirals and non-antiretrovirals, but also between non-antiretrovirals and non-antiretrovirals, because some people are on so many drugs that these also may interact with each other. And this is really important because I think that HIV care providers must be knowledgeable about pharmacology-drug interactions to make sure they provide safe care to people living with HIV. So in our practice dedicated to people aging with HIV, we make sure that we investigate all co-medications at every single clinic visit, including remedies and medications that are bought over the counters, herbal, recreational drugs, alcohol intake, and we look at details at the risk for drug-drug interactions. We have published, for example, the anticholinergic risk in people aging with HIV, and we saw that some people in our clinics are at a high risk of developing side effects to anticholinergic drugs. This is mainly people on boosters and on anticholinergic drugs that might be increased by ritonavir or cobicistat, but it's definitely something that needs to be taken into consideration, especially in aging people who might develop frailty, be at risk of failure. Anticholinergic drugs can cause confusion, loss of balance, and so on. People who are aging with HIV that attend our services are also tested for testosterone, total and free testosterone, especially when they have high cardiovascular risk or osteoporosis. We also make sure that we check whether women aging with HIV experience perimenopause or menopause and have symptoms and need to be referred to our menopausal clinic for women living with HIV. If we see trans people aging with HIV, we review their symptoms also and their risk for drug-drug interactions between antiretrovirals and any other drug that they may take. We also perform a few cancer screenings or make sure that the cancer screenings are performed routinely. We do test for PSA. Obviously this has pros and cons, but we have actually diagnosed some prostate cancer in our cohort. The reason is not because prostate cancer is more frequent in people living with HIV, but it's because some of our patients do not attend their GPs and might not undergo national screening programs. Anal smear, we do performing when it's possible, and we make sure that women have their cervical smears and the mammography done as per national screening programs. In terms of cancer, we know that there are some cancers associated to HIV infection, but the majority are not. However, data show that some cancers may develop earlier in life in people living with HIV compared to people who do not have HIV. Therefore, cancer screening is needed when possible. Very importantly, we test for cardiovascular risk. And mainly via the measurement of cardiovascular risk calculations by equations like Framingham or Q-risk-2 or Q-risk-3. And also we request the coronary artery calcification score, which is a CT scan of the heart to see the calcium deposits in the coronary arteries. So as I said, we do make sure that we calculate cardiovascular risk with either Framingham or Q-risk-2. This is important because when the risk is high, we can support people living with HIV attending our clinics with improving their diet and exercise levels, so improve their lifestyle. This has been shown to be important. We need to make sure their blood pressure is controlled and their cholesterol is controlled. So we have actually a service that supports people aging with HIV, make sure their health is maintained. And we also have a metabolic clinic that looks at people with high cholesterol, diabetes, and they're linked with dietitian and physiotherapists, again, to ensure diet and exercise are implemented, promoted to increase the health of our population living with HIV. The coronary artery calcification score, as I said, is a CT scan of the heart. We do perform it, we look at the results, and when the score is high and shows that the blockage in the coronary arteries could be remarkable, we refer our patients to a cardiology HIV clinic that we run in our service. This to us has been important, and we also published our results, as some people with the high Framingham score, for example, are advised to start statins. However, the coronary artery calcification score may be very low. And if they don't tolerate statins, sometimes we just monitor their health and make sure that they continue with a healthy lifestyle. However, vice versa, some people show low results in the cardiovascular risk equations. However, their coronary artery calcification score is very high. And therefore, we do refer them to the cardiology anyway for advice on how to manage that. We also look at people's bone health by requesting bone mineral density and measuring the FRAC score and measuring vitamin D. We know that people living with HIV are at an increased risk of low bone mineral density and fractures, and this has been shown to be true for both male and females, and it has also been shown to be especially associated to certain antiretrovirals. The EACTS guidelines importantly suggest to consider a DEXA scan in postmenopausal women and in men above the age of 50 years. We do calculate the FRAC score, and we make sure that people who are aging, whose balance might be compromised and who may start to develop frailty, are referred to our care of the elderly and HIV clinic to see what kind of support they can actually receive from the geriatrician. Finally, we look at people potential neurocognitive disorder. We look at their social situation, whether they're isolated, and we ask them if they are concerned about their memory, concentration, and cognition, or if anybody around them has expressed concern about their memory, concentration, and cognition. If the answer is yes, we administer questionnaires to look at their depression and anxiety. And we administer an everyday memory questionnaire to see whether they show any symptoms of impaired memory. And we refer them to psychology, to neurology, or to neuropsychometric testing, as we have teams of neurologists and psychologists that work within the HIV department. So in conclusion, we have had more than 10 years experience in managing a dedicated clinic to people aging with HIV. Today, we actually expanded the clinic to make sure that every single clinician who sees someone who is above the age of 50 performs this kind of tests and investigations to make sure we deliver the best care we can to people who are aging with HIV, and we either manage a comorbidity or prevent it when possible. Importantly, we have this co-specialty clinic that I mentioned through my talk, such as the care of the elderly HIV, or cardiology HIV, or neurology HIV, and many others, where we refer our patients to make sure that their comorbidities are managed by specialty doctors that have an interest in HIV and understand HIV medicine too. We have published our experience approximately 10 years ago on this clinic dedicated to people aging with HIV. And this year, we published our 10-year experience with health outcomes and how we're actually going to move forward and continue to provide care to people who are aging with HIV. Thank you very much for your attention.